evening and welcome to Doctors on Call. I'm Dr. Mary Owen, Associate Dean of Native American Health and Director of the Center for American Indian and Minority Health at the University of Minnesota Medical School. I'm also a family physician for the Fond du Lac Band of Lake Superior, Chippewa. And I'm your host for our program tonight on upper extremity, shoulder, neck, and back problems. The success of this program is very dependent on you, the viewer, so please call in your questions tonight or send them in ahead of time to our email address. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Matthew Davies, a neurosurgeon with Orthopedic Associates of Duluth, Dr. Ryan Harden, a family medicine physician with the Gateway Family Health Clinic in Sandstone, and faculty member at the Medical School of Duluth, Dr. Anthony Burrows, a neurosurgeon with Essentia Health. Our medical students answering the phones tonight are Gabe Graves from Esco, Minnesota, Jamie Vergine from Lester Prairie, Minnesota, and Sophie Wong from Springfield, Missouri. And now on to tonight's program on upper extremity, shoulder, neck, and back problems. Welcome, doctors.
Thank you.
Thank you. It's good to be here.
We have one question ahead of time, so I'll ask that, and then we don't have any others, so we'll just wing it, have some conversation, okay? I'm going to ask you, Dr. Harding. My shoulders are becoming rounded and head bent forward. It's difficult to straighten up. Are there exercises or physical therapy that can help? I'm 75.
So I think that this patient is asking questions about their posture, and it's difficult to change your posture in the short term. So for this person, if they were having discomfort or pain, I would probably recommend that they look at the way that they're carrying themselves throughout the day, what their posture's looking like. Maybe where they're working, if they were sitting all day long, if they had a desk where they could stand up. If they're looking down at a monitor or down at their work all day long, I would probably elevate the monitor if I could so they're looking at eye level, and I think that would help to give them better posture.
And physical therapy might help as well, just to strengthen some of the muscles so that they don't have pain later on, right? Yeah.
Yep.
Now, you and I as family doctors see a lot of folks for back pain. I mean, every time we turn around, we're seeing another back pain.
Probably 1 or 2 people a day.
Right,
Every day, yeah.
right. So, colleagues, when should we be thinking about referring people for back pain?
Yeah, so back pain in and of itself, pretty a non-specific finding. As you know, you see it every day.
Mm-hmm.
Really, when people are having difficulty walking or they're having a lot of lower extremity or upper extremity symptoms is when we start to get more concerned about there being a neurological problem.
Okay. Dr. Burrows, anything to add?
I agree with that. You know, pain, I guess, that remains refractory to conservative treatments that we usually use, physical therapy, and then more advanced treatments like injections, may warrant a visit or at least a consultation with us. And we're often pretty open to receiving a message from our colleagues in primary care, just inquiring if there's any other tests to look at, things to ask about, because it's a very common problem, and there are a number of things that can cause it.
Dr. Davies, what do you end up seeing the most in your clinic, or what do you end up having to operate for the most often?
So I do a pretty fair number of both cervical and lumbar spine problems. So neck and back problems that have been progressive, usually degenerative problems. So
like
I'm
arthritis?
in arthritis is a
Okay.
big portion of it, or what we call degenerative disc disease.
Okay. Dr. Burrows, same?
I would say our practices are probably very similar. Degenerative conditions of the cervical and lumbar spine, we end up seeing a fair number of traumatic problems at Essentia, involving both the thoracic and cervical and lumbar spines. And then we have oncologic problems, so metastatic tumors or primary tumors of the brain and spinal cord. So that I would say probably in that order, the problems we see.
Okay. Dr. Davies, do I need to have surgery? This is from William from Grand Rapids, wants to know, do I need to have surgery if I tore my front shoulder ligament?
So
Maybe Dr. Harden.
Yeah,
Go ahead.
probably be a good question to defer to my orthopedic colleagues.
Or Dr. Harden?
Or
do you
Dr. Harden.
If somebody tore it, well, I don't know what ligament that's referring to, but generally when somebody has pain in their shoulder, there's a lot of things that can cause that. It could either be from a tear, commonly the rotator cuff, or a biceps tendon tear. Usually we can figure out if somebody has a tendinopathy, which is just inflammation in a tendon or muscle, or a muscle. Clinically, by the questions we ask in the physical exam that we do on the patient, we can usually tell if they have a tear or if it's just a with conservative management, exercises, resting it, avoiding certain movements. But if somebody has a tear, and especially if they have weakness, that's something that might need surgical intervention.
Okay. All right, for any of you, is over-the-counter glucosamine helpful with bursitis? Probably Dr. Harden again.
I don't think glucosamine is used to treat bursitis. I would probably lean toward something that's going to be anti-inflammatory, like a steroid injection or ibuprofen or NSAIDs for bursitis. Usually glucosamine sulfate, about 1,500 milligrams a day, is typically used for the treatment of arthritis, osteoarthritis.
Okay, great. But you mentioned a couple of other treatments, NSAIDs being non-steroidal anti-inflammatories like ibuprofen, commonly used. And then you talked about I think you mentioned steroid shots. Do either of you use steroids a lot before you go to surgery and back?
Yeah, I would say that's a pretty common medication, whether delivered through an injection or orally, to try and take away inflammation in and around the nerves where we're operating for the most part. And so that's a pretty common thing that we'll use, if nothing else, to temporize people's symptoms before we ultimately pursue surgery. In many cases, between 50 and 75% of the time, that's all we need to do, take away the inflammation, and that's usually our goal. I know we've talked about this before, trying to treat everything without an operation if possible. So
it sounds like you're saying you can use it one time, occasionally use it only once?
Well, it all depends on the person's other medical issues. We can use several steroid injections. We tend not to use more than 1 or 2 rounds of oral steroids unless there's a really compelling reason to use more.
And Dr. Burrows and I were talking about this before. 2 different types of injections that we use. Steroid injections are more therapeutic, designed to treat the problem with the anti-inflammatory effects. And then we can also use what's called diagnostic injections, either lidocaine or an agent like that, to help us pinpoint where people's problems are coming from.
And then what do you do?
And then if we can localize it to a specific nerve, we can often treat that surgically.
Okay, great. Thank you. A caller from Virginia, Minnesota, and I'll ask you, Dr. Davies, because you're sitting right next to me, although you might defer this again to Dr. Harding. Are there any new treatments for old, worn-out shoulders?
I will also defer.
Well, probably what the caller is referring to in terms of a worn-out shoulder is degenerative arthritis. And we all get it. It's like when you drive your car around on the streets, the tires eventually wear out. When we use our joints throughout our life, the joints eventually wear out, osteoarthritis. Generally, the progression of treatment for osteoarthritis is we start with certain physical exercises, maybe a referral to a physical therapist. If that is ineffective, there's over-the-counter pain medicines, acetaminophen, ibuprofen, NSAIDs. If that's not effective at controlling somebody's pain, then we resort to steroid injections, which I do in my clinic on peripheral joints. And sometimes patients will get 2, 3, 4 years of relief out of steroid injections. But eventually, if that joint is really worn out, doesn't respond to steroid injections, it's time for surgery, joint replacement.
And how many times, and this is for the back too, how many times a year can you get a steroid injection? How long are they expected to last?
I usually limit steroid injections to every 3 months at the most frequent. There's certain situations you would do it more frequent than that, but usually I tell patients every 3 months at the most.
Dr. Barros, I see you nodding. Okay.
Agreed.
Okay. Are there any risks to, what are the risks? There's risks to everything. What are the risks to steroid injections?
So most common risk with injections is pain, either pain locally at the site or following the trajectory of the nerve that was injected. On very rare occasions, you can get a puncture headache, so you can get a spinal fluid leak associated with an injection. Okay. Very uncommon, but one of the risks.
Well, since you're answering questions, I think you neurosurgeons can appreciate this one. I have a twang in my shoulder, upper back region. Would a chiropractor help? I guess you can answer the chiropractor question, but I also have more general questions.
Yeah, in terms of chiropractic care, I very much appreciate our chiropractic colleagues in the area. I think a lot of them do very fine work. And so chiropractic manipulations there's a wide range of what they do. Frequently for the upper back and shoulder blade pathology, they do really good in terms of the manipulation and taking the whole spine into consideration. often with a variety of different treatment options that they have, very successful.
Thank you for that. What I was getting at is that when patients come into our office for upper shoulder, one of the things we look for is a spinal problem, so the testing that comes with that. But thank you for that answer. All right. How can I tell the difference, from Hermantown, how can I tell the difference between shoulder nerve impingement versus bursitis? Dr. Harden?
Well, the difference between shoulder nerve impingement and bursitis, both of them will cause pain when somebody elevates their arm above horizontal. Usually nerve impingement will not respond to a steroid injection, whereas bursitis will you'll get a really good response from a steroid shot, from a steroid injection.
All right, thank you for that. Dr. Burris from Dory from Proctor, Minnesota wants to know, she has significant cervical arthritis. What ongoing practices can she do to help stop the progression and help her current symptoms?
That's a great question. And I mean, the honest answer is there's not a lot of things we can do to halt that progression. One easy thing to do is if you're smoking, stop smoking. That inflammation is terrible for your whole body, but especially for your spine. Regular exercises and stretching, usually with the guidance of a physical therapist, can be quite helpful to establish a good routine and a good plan. And that's probably the best things we can do, try to maintain a healthy weight and to stay active. But unfortunately, we don't have great ways at preventing that progression.
Okay, thank you. Dr. Davies, do sciatic nerve issues cause numbness and tingling in the feet?
So yes, they can. Numbness and tingling in the feet is also commonly seen in diabetic neuropathy. So people with long-standing diabetes, one of the most frequent symptoms is stocking glove numbness, so tips of fingers, tips of toes, and it can progress upwards. But yes, peripheral nerve compression, sciatic nerve compression can mimic those symptoms.
Anything to add, Dr. Burrows?
I think that's well said.
Okay. All right, shoulder doctor. What is the future of shoulder replacement, and what is the recovery time typically like?
Well, I'm not an orthopedic surgeon, but the results that we get in modern shoulder replacement, which is also called shoulder arthroplasty, are dramatic improvement in shoulder pain. And so as far as the future of joint replacement, I think that when somebody has a shoulder replaced, either a regular arthroplasty or a reverse shoulder, as they're called, they're going to be pain-free most likely. And I usually tell patients you're going to have 90% of your pain gone after 6 weeks, and then after 3 months they should be back to baseline in terms of their activity level and abilities.
All right, I have a question I'm not sure of, but I'll ask the question. I have arachnoiditis and back issues. How does arachnoiditis affect treatment and/or surgery for my back?
Yeah, that's a tricky one. I think we would all struggle with that answer, but I can try to give it a shot. So
Okay.
arachnoiditis is inflammation of the little nerve roots inside of the spinal canal. So at the very bottom of our spine, our little nerve bundles that we call the cauda equina. These small little nerve fibers float around in the cerebral spinal fluid. Arachnoiditis is essentially inflammation of the covering of the nerves inside the spinal canal. Notoriously a very challenging pain syndrome to treat. There are a lot of different treatment options that exist out there, but yes, knowing that ahead of time will help dictate whether or not you are going to respond to some of the more traditional spine surgeries that we have to offer.
Okay. Go ahead, Dr. Burrows.
Yeah, I would say that that's a very difficult syndrome to live with, just because it's so hard to treat and so hard to diagnose. And I think any spine surgeon that you meet with will probably take that into consideration.
Okay. Dr. Burrows, we'll start with you on this one. I heard of an MRI recently showing disc bulging arthritis and central canal stenosis in C3, 4, 5, and 6, 7. What are some options? What are the things that the doctor might talk with them about?
Well, and I guess it really all depends upon the symptoms that the patient's having. The thing we worry about the most in the cervical spine is compression of the spinal cord, and that can lead to very severe symptoms. It begins with really subtle things that you may not notice: numbness in your fingertips, loss of dexterity, poor balance, and can progress to weakness and paralysis if not treated in time. But things like disc bulging are pretty common on MRIs, and I suspect that most of us on the panel probably have some on if we were to get MRIs. So it really depends, A, on the symptoms, and then B, what the actual pictures look like. So some basic options, provided the symptoms aren't terrible, would be physical therapy and that same stretching and exercise routine we talked of earlier. For more severe symptoms, we might talk about surgeries, both from the front and back of the neck, and it really all depends on what the overall anatomy looks like.
Anything to add, Dr. Davies?
Yeah.
No, I agree. That's well summarized.
Okay. I find it particularly hard sometimes to have patients understand that, like you just said on the MRI, that the findings aren't necessarily enough on their own, that you can see odd. Go ahead.
And yeah, I'd add that the language used to interpret MRIs is highly variable, and really
That's a good point.
a spinal specialist is really the one that's going to help determine, how to interpret that. And so, bulges, herniations, desiccation, we see these words all the time, but there's not a uniformity in how to apply them.
Thank you for that.
Yeah.
And I'd say that Dr. Burrows and I get the luxury of being able to sit patients down and do a lot of education. That's one of my favorite parts of my clinic visits, being able to take this complicated MRI report and then walk them through one space at a time, showing exactly what that means.
That's fantastic.
Yeah.
All right, a caller from Duluth, mid-60s, fell last year and tore his rotator cuff. He was required to do weeks and months of PT before he could do surgery. Why does this is a great question. Why does this happen? Is it insurance? Does it delay recovery versus immediate surgery?
That is a good question. Sometimes people will, irrespective of what their MRI shows, if they have a rotator cuff tear or just a rotator cuff tendinopathy, sometimes people will have recovery of their symptoms without surgery. And surgeries have potential complications. We like to avoid surgery if we can. Think of it, in most cases, as a last resort. And this person might have fallen, and they might have had that rotator cuff injury decades ago, and then they just fell, had some acute shoulder pain, and they had an imaging study that showed that they had a tear, which wasn't at all related to the injury. So it's something very commonly we will recommend a course of rehab before we resort to surgery.
This is what I like about this show, is that we're able to kind of give the back talk and really confirm what people have heard from their doctors, that surgery is not risk-free, and that we don't jump into it without thinking hard about what it might do. The good versus the overall good versus the harm. So, a caller from we did that one. Dr. Davies, what are your thoughts on stem replacement for shoulder issues? Back to you, Dr. Ryan.
On stem replacement?
Yeah, stem cell replacement for shoulder issues. I don't know anybody.
To be honest, in my practice, I haven't referred a patient for stem cell therapy for shoulder issues. I think that might be on the horizon. In my practice, it's somewhat experimental. I haven't had any of my patients that have had that therapy.
Dr. Burrows, I saw you look interested.
I'm very interested. It's a very promising treatment. I don't know of any well-run trials that would show that it's been effective. That's the hope, is that we can find treatments that will affect both the skeletal and axial bones to prevent this arthritis, but we don't have it yet, unfortunately.
Okay. Nothing to add, Dr. Davies?
I agree with both.
Okay.
Promising, but not there yet.
Yeah.
I'll let you answer this one then. Could stenosis in the vertebrae of a nerve to the arm cause tremors?
Let's see. So, if I can try to interpret that,
Yeah.
if you had spinal cord compression,
so.
not necessarily the nerve,
Mhm.
bad enough, your myelopathy was bad enough, which is what we call our spinal cord compression, you can get a syndrome that looks like a tremor.
Okay.
Hyperreflexia or increased reflexes can
Mhm.
kind of mimic tremors. So yes, the short answer would be yes, you could
Okay.
have that.
Anything else to add? Agree with that one. Denny from Matoa asks, I have a dull, consistent ache in one side of my neck. Could this be a pinched nerve? Dr. Burrow?
Potentially. More likely, based on just the description, might be muscular, and it could be facetogenic. The facets are sort of the knuckles that allow your neck to bend forward and backward. And so, like a lot of things, we would treat that with a course of physical therapy, stretching and flexibility exercises, an evaluation with probably your primary care physician and possibly imaging studies. But a lot of it would be based on the history and some probing questions that we'd ask in person. You know, the kind of pain, where it goes, what makes it better, all those things that we ask almost everybody we see.
Which brings me to the next question, very similarly. Having shoulder pain for a year, what can I do without insurance? Any home remedies? So
Exercise. High repetition, low impact exercise frequently. I wouldn't do any exercise that would generate pain. Don't overload the shoulder. Ibuprofen, Tylenol, and give it a little bit of time.
And if it doesn't, then
Go see your doctor and consider a course of physical therapy, maybe a steroid injection.
And we do have clinics that, there's one on the West End where you don't have to have insurance, so you can go. Kara on the North Shore had a frozen shoulder, and one of her shoulders was frozen. She heard there's a greater chance of getting it on the other shoulder. Is there anything she can do to prevent another frozen shoulder?
Well, frozen shoulder is caused by diffuse inflammation in the joint capsule in the shoulder. So, absolutely, activity. I would say swimming, overhead activity that doesn't cause pain in the joint, and again, high repetition, low impact exercise like swimming. You wouldn't want to do any significant weightlifting or something like that that might actually worsen it or cause trauma, and maintaining range of motion to prevent frozen shoulder is really important.
Thank you. Dr. Barrow, from Sarah, what are the best and worst things you can do for spinal health, starting young and as you age?
Well, we can easily start with the worst things. I think we can all think of a lot of things. But, if obesity, it puts a lot of strain and stress on your back and causes your discs and facets to wear out much more quickly. Similarly, I mentioned before, smoking makes things much worse, just generally increasing that inflammation. And then inactivity. And I think those are the three worst things you can do. So the three best things you can do are to be active, be healthy, don't smoke, and try and maintain a healthy weight, which is difficult. But there are a lot of options out there. And we see people all the time from all walks of life who work in manual labor or desk jobs who have similarly degenerated spines. So I would say live your life as you normally would. Try and maintain a healthy weight, stay active, and don't smoke.
It's interesting that you mentioned the construction-like work, the laborers.
Sure. Yeah.
Oftentimes I'll have patients who come in and think that because they labor all day, they're doing the exercise that they need to, and yet we know from having seen so many patients that if you're not watching out for your back and doing other exercises as well.
And I would say it's a great way to maintain strength, but you want to balance it out with core strength and also balance that with flexibility. And so there are exercise programs. The SpineX program that's available through several health centers is a very great way to strengthen your core and do so in a healthy, progressive way.
Okay. Dr. Harding, my son's left arm has gone numb because of a backpack, a very heavy backpack. What's going on and how do I fix it?
That's a great question. So what's happening, I think, is the backpack's too heavy. And the strap of the backpack is pushing on the brachial plexus, which is a bundle of nerves that go from the neck into the arm. I would say get a different backpack, or sometimes you can get a backpack that wraps around the waist where the weight is distributed, or decrease the amount of weight in the backpack. And usually with what's called backpacker's palsy is the name of that condition, if the numbness and tingling is intermittent, they're going to be fine. But I would not put so much weight in the backpack.
Or put both arms up
Yeah,
instead of just one. We see students do that a lot. We don't have too long, but I think we might get this one in from Lois. Can you explain the structure of the trapezius and what injuries of the trapezius present with symptoms, etc.?
So the trapezius is a muscle that goes from the shoulder to the back of the neck to the mid-back, and injuries that will present with trapezius pain, the trapezius is a very common muscle to have a muscle spasm in. So, and usually when people have that, they can reproduce the pain by pushing on their trapezius, which is right here. And that's amenable to physical therapy, NSAIDs, and sometimes muscle relaxers like cyclobenzaprine or Flexeril.
And I think this is the time of year when we start to see it more. People hunched over the driving
Yeah.
get really bad trapezius pain. All right, I think we might squeeze one more in. I have mild spinal bifida and mild scoliosis. When I bend down, my right buttocks and mid upper leg goes numb. What is the cause? Are they related to those things?
In short answer, they could be. That would require additional imaging. Typically, we would want an MRI of the low back. That would allow us to look at the nerves a little bit more and understand the nature of your spina bifida and scoliosis.
Okay. Anything else to add, Dr. Burrows?
No, perfect.
All right. Well, thank you all for being here.
Thank you.
I want to thank our panelists, Dr. Matthew Davies, Dr. Ryan Harden, and Dr. Anthony Burrows, and our medical student volunteers, Gabe Graves, Jamie Virgin, and Sophie Wong. Please join Peter Nalen, Peter Nalen, sorry about that, next week for a program on ENT problems, including sleep apnea, when his panelists will include Dr. Todd Freeman, Dr. Robert Gruhl, and Dr. Thomas Gustafson. Thank you for watching, and good night.